Hello, everyone. This is the Ophthalmology Business Podcast, where we help you develop your ideal practice with help of other doctors and experts. The topics we cover include marketing, management, leadership, recruitment, HR, mindsets, and more. I am Narain Arulraja, the founder and one of the co-hosts of this podcast. Every listener of this podcast is welcome to join the Ophthalmology Business Academy, www.obacademy.org. The membership is on us, and it's our gift to you. Today, I'm excited to talk to Dr. Sruthi Arepalli. She is a uveitis surgeon and someone who specializes in retina. She's an assistant professor at Emory Eye Center, and it's going to be an awesome conversation about how to build a surgical uveitis and retina practice. Dr. Arepalli, welcome to the podcast.
Thank you so much for having me.
I really appreciate you taking the time to talk to us. And I'm sure some of the people listening know who you are, but perhaps some don't. So can you tell a little bit about yourself? Who are you? How did you get into medicine and ophthalmology? Your story, and of course, take us all the way to where you are today.
Yeah, absolutely. So I'm Sruthi Arepalli. I'm an assistant professor at Emory University, where I practice both vitreoretinal surgery and uveitis. I did the majority of my training at Cleveland Clinic, so I did residency there. And then I left for 1 year to KCI, where I did my uveitis fellowship with some phenomenal mentors. And then I returned back to Cleveland Clinic to do my vitreoretinal fellowship. My story, I think, is a little interesting because I did a year in private practice before transitioning over to an academic center. In terms of how I got started with all of this, I grew up in Maryland, in the DC area, and always thought I wanted to go into medicine, but I thought I wanted to be a pediatrician, actually, up until the day before applications were due, when I was on my pediatric rotation. And I realized that while I liked the medicine of pediatrics, it didn't stimulate me in a way that I felt like my field should. And so I started reaching out to mentors to ask if I could shadow, and decided that ophthalmology was a better fit, both for the procedural basis and the surgical basis, but also I really fell in love with the idea that I could be instrumental in helping someone regain or maintain their vision. And to me, that felt like a calling that I should invest time into. So I actually ended up taking a research year during my medical school time because I decided so late, and did a year in ocular oncology research before applying to ophthalmology itself. And then I met some mentors at Cleveland Clinic who, showed me how fulfilling it could be to do both of these subspecialties, uveitis and vitreoretinal surgery. And so I sort of modeled my career after what they had done. And I gave myself a chance to explore all the subspecialties, and again, sort of gravitated towards pediatrics initially, but then realized that I was the most excited to attend their clinics and see their patients. And so I figured that I had to spend the extra time and do both fellowships as well.
Cleveland Clinic is an impressive place. I've been there and I had the opportunity to meet some amazing people there. It's they're very committed to, like solving the unsolvable, like the tough cases and, the tough, like they go where nobody else goes. So that's an awesome. How long were you there? Like, were you there for a total of how many years?
So I did residency there. So I did my internship in DC, and then I went over there for 3 years for residency. And then during my residency period, I had really long conversations with a couple of my faculty trying to decide what it is that I wanted to do. And we traditionally apply at the beginning of third year. And I had thought, okay, I really like retina. I'm going to do retina surgery, but I think I want to do retina surgery plus something. And I found myself that I kept coming back to this one particular attending's clinic who saw uveitis and retina and really just enjoying the entire process. So then I made the decision to do my uveitis fellowship first. So I left for a year, went to KCI, where I trained with also incredible people. And then during that time period, I applied for vitreoretinal surgery. And I felt like the combination of the both has led me to the perfect job now.
Let's jump into our conversation today. The people that I know typically don't do 2 fellowships. What motivated you to do 2 fellowships? And also, get involved in surgical patients, both in uveitis and retina.
Yeah, so it's an interesting process because during my entire application process, I had people give me all sorts of advice. And some of the advice was that I don't truly need to do both fellowships, because if I went to a place, so I trained at Cleveland Clinic for retina surgery, and you do see a good amount of uveitis during your retina fellowship. The thought process was you don't need to spend an entire year doing the uveitis fellowship. But I was pretty invested in becoming sort of this really tertiary end care person for these eyes. And I wanted to give it the entire fellowship experience and then bring that knowledge to whatever job I took. So I invested in the 3 years. And I feel like that level of nuance in approaching a patient and being able to see them through the uveitic lens and the retinal surgery lens has just broadened my scope and my ability to take care of these patients.
Yeah. Do you find that, like looking back, if you had to do it again, would you do what you did? I mean, in terms of the extra year?
Absolutely. I know that some people, are all about saving time so they can get to their last step. But for me, this entire process has just been a growth pattern, and I still think I'm growing and learning. And so for me, I don't think I could have gained the knowledge and the incredible exposure that I got under such, watchful and wise people who were teaching me if I was practicing on my own. And so I'm so grateful and happy that I did that extra year.
Well, that's awesome. What are some of the difficulties you have faced when building your practice, and especially a practice that specializes in two things, uveitis and retina?
Yeah, so building in these two areas, it's amazing, and I wouldn't trade it for a day. I will say that when you're starting out, there's often competing interests in which direction you want your growth to go. And I say that because most people enter ophthalmology being general or having one fellowship. And so it sort of is a little bit more of a straightforward path that they grow in that one subspecialty. But for me, it's always this balance of building my uveitis side, but not letting the uveitis side take over everything, or building my VR side and not letting that build and take over everything, and maintaining this delicate balance of about 50-50. And I think also when you're starting out, you sort of feel like you've got one foot in both camps, and you're trying to, while you're growing in both these subspecialties, do a really good job in both of these subspecialties. And it almost feels like it's going to take a little bit more time to get comfortable. And just shifting my mindset to understanding that I'm dealing with some very difficult patients, and it's okay for that extra 6 months or a year to feel like I've got things to the level that I'm happy with. And then again, like I said, maintaining that balance is always a difficult and tricky thing.
Now, I'm just curious, like listening to you talk. Tell us a little bit about your practice. When did you go out on your own? What is it like? Is it fee for service? Is it, just give us a kind of a backstory. And I just wanted to kind of find out where you are and what are some of your observations as we go into that a little bit.
Absolutely. So I'm in an academic center right now. And so Emory is sort of this tertiary care center where we get some bread and butter, but a lot of our scope is really these tertiary intense referrals that come in from the community. And
Okay.
that's what attracted me to join them. And so that's important to know for a young person who's starting out, because that might mean that you're going to see a little bit less bread and butter. So for retina, a lot of our bread and butter and revenue generating things are injections. And we do a fair amount of those, but I would say that my practice, the majority when I'm at the main campus where we see a lot of our crazy referrals, a lot of it's tough surgery and complex medical care. And so that's important for a young person when they're evaluating what they want their bottom line to be and what they want their growth to be, to understand that you usually can't have both a ton of bread and butter and a ton of complexity. For us, we have a system where we have our base salary, and then there's our view bonuses that you can hit above that. I'm only 1 year in, so I'm not off of our base salary and guaranteed bonus structure. And so, but from what I understand, people who are above me have no trouble hitting that. It's just a matter of kind of tilting your practice towards what you want.
Makes sense. In a large setting, right? In a big setting, any nuances, anything that you need to kind of you didn't expect or you had to get good at to be successful? And is it even for everyone, or is it challenging sometimes?
So I think that growing in a system like this may not be for everyone, just because there are a lot of days where you question, how much you're doing for these end stage eyes. And I think that's a totally normal feeling to have. I had a lot of conversations with my retina chief when I started because I knew I had exceptional training and I knew in my core that I was doing a good job. But when you step away and you look at your patients and you see how, sick they are and how much attention they need, you do ask yourself, am I doing a good enough job, essentially? And when I talked to my retina chief, he kind of laughed at me, and he's been there for, 20 plus years. And he calls Emory the ICU of eyes. He said that all the difficult cases come to us. And he's like, that feeling is very normal. He was like, you are doing a good job. You just are, instead of having a clinic full of patients who are easy to maintain and doing well and really appreciative, you're getting a clinic full of patients who've seen 4 doctors and then are coming to see you. And they're bringing their emotional baggage and their expectations and their poor vision into your clinic. And you just have to adjust your mindset. But that really helped me when I was building at Emory. So I started embracing that feeling that I'm not going to be able to get everybody absolutely perfect, but I am going to provide a service that's absolutely needed in our community, because as our community doctors are incredible. They're wonderful. And I truly believe that when they send to us, it's because they want a third or fourth opinion. And they feel like maybe our system is better equipped to take care of these patients. And so just embracing that feeling of, okay, I'm not going to be able to make everybody 20/20, but I am going to be able to help, has shifted. And then in terms of growing my practice in Emory, I mean, Emory is a huge system. We have a ton of doctors. But what's really nice about my position is I'm the only one who does my 2 subspecialties. And so naturally, there's a funnel of difficult patients that come to me. And I've always been the type of person that says yes to everything, but especially at Emory, just constantly saying yes when people call me, when they email me, even within Emory, and adding them on, even if it means I'm going to stay late, because I realize if people are calling me, it means they think that I can actually help this person. And I don't want to be the one that puts a barrier in that place.
Right. So it's really being focused on, working with people, like being open-minded and just, like, did you actively reach out to others to kind of build your practice, so to speak, and build relationships within the
Yes,
immune system?
that's a great question. So I actually, Dr. Purnima Patel, who's big in AAO, she's wonderful. She's been a great role model for me. And she was at Emory for a long time. And so I reached out to her to ask her how she grew her practice. And she gave me some of these tips that I just talked about. But she's also been wonderful about promoting me within the community. And so she's heavily involved with our state organization for ophthalmology. And she's taught me that by just being present at these meetings and introducing myself, people can put a face to the name of a new hire at Emory that is willing to take on these, what I lovingly call, difficult train wreck cases. And so just by being there, they understand there's another person they can reach out to. And so I've made it a goal to go to these meetings, to introduce myself, to give a small talk, and then give out my phone number and my email to anybody who asks for it. And it's just made it easier to get patients in.
Thank you. What are some ways outside of seeing patients that you have been able to grow locally?
Yeah, so part of that has been going to these business meetings or these ophthalmology society meetings that I mentioned, and that's been one of the strongest things. The other things that I've done, and I've gotten feedback that people enjoy this, is that I write a lot, and I enjoy writing for Retinal Physician and other retinal magazines that's on these topics in uveitis that I think retinal doctors should know about. And so by sharing this information, I think that gets the word out there that I'm competent and excited to deal with these patients, and that's grown my scope as well. And the other thing that I've done is getting involved in research. And so I enjoy presenting a lot of these bigger retrospective studies looking at our patients and their outcomes, because we have this huge wealth of knowledge at Emory. And by doing that as well, I've been able to show people that I'm interested and motivated, and people then also associate me with these diseases and then send me those cases as well.
I bet you looked at lots of opportunities before you picked Emory, right? Like, what were some of the things, like, I mean, assuming like some of the listeners are in that stage of making a choice, like what were some of the things that you think somebody should look at, or what did you look at?
That's a fantastic question. So I was in private practice for a year before I joined Emory, and they are a phenomenal practice, and I learned a lot. The one thing that I missed was having trainees around, and I felt like having a resident or a fellow with me really motivated me in a different way because they ask so many questions and they almost force you to be the best version of yourself sometimes, because you not only have to take great care of your patient, which you're going to do in private practice or academics, but you also have to justify it to someone who's learning. And I sort of missed that challenge. I did look at a variety of places when I was applying for this job and ultimately made the best decision based on what worked for me and my husband. But the thing that drew me to Emory in particular was that, again, I was just fascinated by this culture of saying yes to the hardest cases. And I think that trickles down from Baker Hubbard, who's our retina chief, to the entire staff, is that our main motive is to take care of difficult patients. And our mantra is to say yes, to get the patient in, and then we can assess them. And I really loved the idea of being the person who can walk with a patient from their starting line all the way to the finish line, being able to treat them medically and surgically. And the person who was doing my job before left a couple of years before because they were at a different growth stage in their career. And it just left this perfect opportunity for me to enter and sort of grow my career.
Makes sense. Thank you. What do you consider some of the toughest cases in uveitis or retina?
So the toughest cases, it fluctuates based on week to week, depending on what I'm seeing. But I think some of the toughest cases that I've seen at Emory in particular is that we have this huge influx of retinal necrosis or acute retinal necrosis. So viral related retinal detachments. And I'm not sure what it is. I think part of it is referral patterns. And I think part of it is just that there's not a ton of people who do uveitis and retina in the community that I live in. And the ones that do are exceptional, but they obviously have caps just like we do. And so recently, my clinic has turned into a high flow system of retinal attachments in the setting of acute retinal necrosis. And these are tough cases because you've got to talk to the patient about how they may have a limited visual outcome because they've had such a terrible disease, and how we are probably talking about not just one surgery, but multiple surgeries. And that mindset shift was also really important for me because I was trained in a place where, you get a good mix of bread and butter and difficult cases, but you sort of remember the really good cases and you remember how those are counseled, and you sort of build up your career in your mind thinking, oh, it's all going to be like this. And so just entering the situation where I have to step back and re-educate the patient on what we're dealing with. But those I think are the most difficult because it usually means multiple trips to the OR. It usually means we're talking oil. It usually means that we're going to have a very long and complicated course. But again, it's immensely satisfying because sometimes these patients walk in and say, nobody else feels comfortable taking care of them. And that's what I want to do.
Yeah, I bet this is sometimes this can be stressful, right? So how do you set expectations when you're dealing with these tough cases? Is that like a difficult conversation? Like, are you kind of gotten used to it, gotten better at it?
It was definitely more difficult when I started. And I talked about earlier how I called my retina chief, Baker Hubbard, a couple of times because I was, struggling with this internal struggle of, I think I'm doing the best job that I can. And I know technically I'm doing everything that I should do right. But these end stage eyes don't always have the best outcomes. And how can I get around that in my mind? How can I make peace with the fact that I'm doing the best I can for these patients, but they're not a 20/20 eye? And again, that conversation we had that just impacted me so much, and he probably has no idea that I think about it on a daily basis. But when he called Emory the ICU of eyes, it made me take a step back and reintroduce myself in a different way to patients. And so what I've integrated into setting expectations now is saying, listen, you've had great care in the community. You've had a great doctor take care of you, but they're sending you to me for a very particular reason. They think that they've reached the end of what they can do for you comfortably, and now I'm going to take over. And then I say, and despite, my training and my comfort level with this, sometimes no matter what we do, we may be headed down a road that you're not going to be happy with. And so I've just learned to say that up front. And then what I find is that when we do have a good outcome, patients are pleasantly surprised and they're happy and their faith in the entire system is restored. And then if it goes in a way where you're saying, listen, you're going to be an eye that needs silicone oil for life, and you're not going to have great vision because you've had retinal necrosis or a tractional retinal detachment from diabetes, and you're just not going to do well. I've already set that stage, and I feel like we've repeated it every time. And I just kind of fall back on the fact that Emory sees tough cases, and this is where the tough cases come. And I can't guarantee perfection for everybody.
Thank you. What do you think about burnout in general, and among your colleagues, and even like you as student versus now in the real world? Is that a real challenge, and where does it come from? Is it coming from these expectations, or is it coming from just the politics of all the other people we have to deal with? What's your thoughts? What's your experience on that topic?
Burnout is so important to talk about. I think burnout is this multifactorial process. I think someone who is high achieving and always says yes is at risk for burnout, no matter what system they're in, because I've even had conversations with my administrators who are telling me to stop saying yes to everything because we are reaching a census in my clinic that is, even to them, a little too high, And I think burnout can present itself in many different ways, but a common theme is just that doctors and medical professionals are trained to be this end net that catches all of these patients, and we don't want to let anyone down. I think addressing that is very, very important. So I had a lot of discussions with some of the people at Emory when I started as well on how I can take care of myself while taking care of my patients. And some of the things that they advised for me is that we know you want to be the person that takes care of all these crazy cases and does all this crazy surgery, and that's phenomenal. But some of the best advice I got was to carve out one day a week where I'm doing something that's a little bit more bread and butter, just for my mental clarity and sanity. And I was initially a little resistant to that because I was like, no, I want to be at the main campus all the time doing all of this. But once I actually started integrating that, I realized it breaks up my schedule in a way that's really delightful. So I have a day that's a little bit more straightforward. I see an even higher volume of patients. I do more routine surgeries and routine follow-ups and injections. And that break allows my brain to sort of recharge and get ready for the next week where another day is coming. I think also what's really worked for me, and it's not going to work for everyone, is having variety in my practice. So I think I have an amazing schedule because I have essentially one day a week where I'm seeing a lot of really, really difficult patients back to back at Emory main campus. I have one day a week where I see more bread and butter stuff. I have one day a week where I teach residents at the VA, and that's really fun because I get to see the patients with them, talk them through surgery, talk them through medical management. And it's a way to get to know trainees. And that relationship has been really beautiful, and I really appreciate that. And then I have one day where I operate on these really difficult patients. And then I have one day of administrative and academic time. And I think that routine, that breakup in my routine rather, is really important for me to not feel like I'm doing the same thing all of the time. And it's prevented me from feeling like I'm burning out as well.
That's a great point, because I think variety, especially the way you have set it up, I think is a big blessing or a big advantage you have, right? Because when you do the same thing, it's the same, like that's what burns you out. When you
Right.
mix it up, it's like, you're going on vacation, right? I mean, I'm not saying you're going on vacation, but you're trying something new, like that you didn't try yesterday, a new food, new environment, new people, new weather. So that's why vacations are very refreshing, because it takes you out of your normal routine.
Absolutely.
So it's really smart that you designed it the way you did. As we bring this to a close, any final thoughts, like any information we can share about who you are and how perhaps people can keep tabs on what you're up to?
Oh, absolutely. So, as I said, I'm an assistant professor at Emory University. I have a Twitter account that I'm happy to share at the end of this, and an Instagram and LinkedIn handle. And I've been motivated to stay involved academically in the VR world and uveitis world. So we'll often be at meetings like AEO, ASRS, and other things like that.
Perfect. Thank you so much, Dr. Sruthi. Really appreciate your time today. I learned a ton, so I'm sure our listeners will learn a lot from you. I think you bring a totally different perspective, a totally fresh perspective, and also you're very thoughtful. So it definitely came across because you are thinking about many of these things, not just about the clinical side, but about life itself and the business of ophthalmology. So thank you for all of that. I also want to take a minute to thank our listeners. We appreciate each and every one of you. We cannot do what we do without you. If you like the podcast, please share it with your friends on social media. Also, don't hesitate to write a review for us, either on iTunes or Google Play. Your reviews will help other doctors and practice owners find us. Till we meet again, wishing you all an amazing week ahead.